Well, welcome everyone to our monthly Dunlevie lecture series. Just a few housekeeping and center updates before I have Dr. Blumenfeld introduce our speaker for today. Just a reminder to save the date. We have our Dunlevie MFM Center Perinatal Epidemiology and Population Health Symposium. This focus in the Dunlevie Center is led by Deirdre Lyle and Susan Carmichael, and they are putting together a great symposium. It'll be on February 24th from 3 to 6. It'll be a hybrid event, so either attend via Zoom or in person at the Stanford Research Park, and we'll have more details to come. Our next center meeting is December the 12th. Professor Dame Lynn Chitty from University College London, Great Ormond Street, Professor of Genetics and Fetal Medicine, will be speaking on transforming prenatal diagnosis of monogenic conditions in the English National Health Service. So please join us for this. Our speaker for today is Dr. Yoav Yinon, who will be talking on fetal neurological injury and complicated monochorionic twins. And I will pass things on to Dr. Blumenfeld for a formal introduction.
Yeah, thanks, Yasser, and thanks, Yoav, for joining us today. And hello, everyone. I apologize in advance. I'm at the airport, and if there's a little bit of noise during the introduction, I apologize. I'll try to be quick, and then I'll go on mute. But thanks everyone for joining us today for the Dunlevie lecture. It's really great to see such a diverse attendance from different disciplines, especially for this kind of talk. And it's really fun for me to present Professor Yoav Yinon, who I've known now for several years and had the pleasure of visiting his unit a couple of years back. Yoav is a professor at the Faculty of Medical and Health Sciences in Tel Aviv University in Israel, and is the chair of the Fetal Medicine Unit in the Department of OBGYN at Sheba Medical Center in Israel. And the unit is really the most established and robust fetal medicine unit and fetal therapy unit in the country. And this national and international reputation, I can honestly say, is largely because of Yoav. Professor Yinon completed his medical training in Jerusalem and his fellowship in MFM at the University of Toronto at Mount Sinai, and then had further subspecialty training in fetal therapy in Toronto under the guidance and mentorship of Greg Ryan, who some of you know. In addition to Professor Yinon's internationally recognized expertise in fetal therapy, he was actually the chair of the Israeli Maternal Fetal Medicine Society, which is the equivalent of SMFM, and he did that between 2018 and 2021, of course, involved before and after that time as well. And really many of the national practice guidelines related to just clinical obstetrics and maternal fetal medicine beyond fetal therapy in Israel were really drafted during his tenure. So his impact on the care of obstetrical care goes far beyond fetal therapy. Germane to this presentation, his research is predominantly on monochorionic twins, congenital CMV, which in many parts of the world comes under the wing of fetal therapy, fetal growth restriction, and of course, fetal therapy. And he's authored over 130 peer-reviewed publications, many of them multi-site international collaboration in very, very high impact journals. He is a frequently invited lecturer at international meetings, often focusing on the management of complex twins. And in addition to his academic and fetal therapy work, he really practices clinically the entire breadth of our specialty, which I think is the kind of provider that we admire. And he still does routine OB care, still does deliveries. And I can tell you he's a very highly sought after obstetrician by many patients in Israel. And in fact, it's not unusual for him to see patients all the way till midnight. And for fun, you can find him running the next day at 5 a.m. before heading back to the hospital. He's an avid runner. So Yoav, I know it's a little after 10 p.m. where you are. Thank you for clearing your clinical schedule so you can join us tonight. And we look forward to your presentation.
Well, thank you very much for this invitation and for this introduction. It's a great honor for me to speak at this forum. So I'll just share my talk. Okay. So the topic of my talk is fetal brain injury in monochorionic twins. And as you know, monochorionic twins are associated with specific complications, specifically twin to twin, selective IVGR and TAPS. I will focus in this talk on TTTS and TAPS and speak a little bit at the end about single fetal death. And as you all know, the underlying condition that causes all these specific complications is the shared placenta and the vascular anastomosis. And since 2004, the gold standard of treatment, sleep for stage TTTS stage 2 and above, has become a laser ablation of anastomosis. So, as you know, we selectively ablate the anastomosis, and since 2014, we started using the Solomon technique, in which we draw a line of ablation between the anastomosis, actually decoronizing the placenta. And I think throughout the years, we've become better in terms of treatment, in terms of a shorter outcome. And today we can speak that the dual survival is almost reaching 70% in most centers, and the single survival is about 90%, which is not bad compared to what we had at the beginning of this treatment. But the two main obstacles when we deal with, I think, monochorionic twins with TTTS is the prematurity associated with this condition and the neurological impairment and the risk of neurological sequelae. So the question is, why do we have a neurological impairment in TTTS? And there's a couple of possibilities. One option is that there is injury even before the laser treatment as a result of hemodynamic imbalance. In some cases, a minority of cases, you already have anemia or polycythemia before the laser ablation. Another possibility is a change in the hemodynamics during the procedure itself, which could cause ischemic damage or hemorrhagic injury. And the third option is a prematurity that might contribute to the neurological damage. So there are actually a lot of studies about the long-term outcome of survivors of TTTS. The first studies are quite old studies. They are based on cohorts between 2000 and 2005. And you can see here that the neurological morbidity, and we're talking here about severe morbidity, so it includes deafness, blindness, CP, developmental outcome, less than 2 standard deviation. And you can see that the largest study of the Priore, they reach a rate of 18% neurological morbidity, which was quite high. And if we sum up all these studies, the prevalence of neurodevelopmental impairment was around 11%. There were no differences between the donors and recipients in terms of the risk, and no differences if there was one survivor or two survivors. Then there were more recent studies coming up, and these studies here is based on a cohort of 2A to 210. So it's the same center from the Netherlands, from Leiden, and they compared this cohort to the older cohort of 2 to 25, which showed 18% neurological morbidity. And in this latest cohort, the morbidity went down to 6%. So there was a significant difference between the later cohort of 6% neurological morbidity to the older cohort of 18%. And the explanation for this improved outcome in terms of neurological morbidity was the fact that we have a learning curve in terms of the treatment. The prenatal care of monochorionic twins have probably improved. Also, the Solomon technique, which was introduced in this center in 2008, they all may contribute to the improved neurological outcome. And then the same group from Leiden came up with a more recent cohort and recent study from 211 to 214, looking again at the neurological morbidity. And you can see that the rate of neurological morbidity did not change compared to the previous one. So it was 3% compared to 6%, but this was not significantly different. So the conclusion was that we probably reached a plateau in terms of the risk of neurological impairments. What's interesting to see in this study is that in more than 50% of cases that had severe neurological morbidity, they were born after 32 weeks. So implicating that maybe prematurity is not such an important contributor. The second important observation here was that in 60% of cases, there was no evidence of cerebral injury on postnatal ultrasound. So our question was, can we detect this CNS injury prenatally? And is it possible to predict the neurological outcome of later survivors prenatally? So in order to answer this question, we took on a study in which we aimed to determine the rate of fetal neonatal and neonatal brain lesions after laser treatment for TTTS, and to try to define the risk factors for such an injury. So we included 83 women who had laser, that's 153 fetuses, and after the laser, they had neurosonogram every 2 weeks, and they all had brain MRI at 28 to 32 weeks and postnatal brain ultrasound. And we found in 11% of fetuses prenatal brain lesions. So that was 17 fetuses, 11% of fetuses. When we compared the fetuses that had brain lesions to the fetuses that had normal brains, we found that the fetuses with brain lesions had the laser done at a more advanced gestational age, 23 weeks compared to 21.4. The rate of postnatal TAPS was much higher. It was 29% compared to 9%. And there was a higher discordancy at birth. When we looked at the rate of pre- and postnatal brain funding according to gestational age at laser ablation, you can see that as the procedure was done at a more advanced gestational age, the risk of brain lesions was higher. We can see here a few examples of patients in this cohort. So this is a 25 weeks patient, 3 weeks after laser. This is the previous donor, and you can see the hemorrhage, the interventricular hemorrhage, and the ventricular megaly. And this is a few weeks later on MRI, progressive ventricular megaly. We can see the bleeding here. And this is the 30 weeks, the same patient with progressive ventricular megaly. We can see the damage to the basal ganglia and the germinal matrix hemorrhage. This is another case. It's 22 weeks, 4 weeks after laser. The blood clots, which we can see here, and the periventricular hyperechogenicity. Here we can see also the irregularity of the lateral borders indicating periventricular hemorrhagic infarction. This is another case, 8 weeks after laser. The laser was done at 24 weeks, and this is the 32 weeks, and this is the previous recipient. We can see the porencephalic dilatation of the lateral ventricle as a result of periventricular hemorrhagic infarction. And another case here with the previous donor a few weeks after laser at 17 weeks, and we can see that damage to the cerebellum. This is the previous donor with the damaged cerebellum compared to the previous recipient which has a normal cerebellum. So the main lesions that we saw were either hemorrhagic lesions or ischemic lesions. Another study by the French group in Paris, they also looked at the rate of fetal brain lesions in patients who had laser ablation. This is a very large cohort of 1,023 cases. I'm not sure what was the rate of patients who did MRI. It's not clear from this paper. So not all patients here underwent MRI, but you can see that the rate of brain lesions here was lower than what we found in our study. It was only 2%. And on average, the lesions were found around 6 weeks after the laser ablation. In most cases, about 80%, the lesions were detected by ultrasound, and 18% were detected only by MRI. And again, most lesions were either ischemic or hemorrhagic lesions. They also looked at tried to define the risk factor for the prenatal brain lesions, and the major risk factors was the occurrence of TAPS or recurrence. So patients who had prenatal brain damage, they had increased rate of TAPS or recurrence. So they concluded that the major risk factor for brain lesion following TTTS is incomplete surgery resulting in TAPS or recurrent TTTS. And this is a recent study, again from Leiden, and they also looked at the rate of fetal or neonatal brain injury. But in this study, they used only ultrasound. They did not use fetal MRI, and they found brain injury in 2% of fetuses and 5% of neonates. And again, when they looked what is the risk factor, the main risk factor was recurrent TTTS or post-laser TAPS and early gestational age at birth. If you look at the type of lesion that they found, 60% of the lesions were focal lesions, again, hemorrhagic lesions or ischemia, and about 40% were diffuse lesions like cystic PVL or encephalomalacia. What they also found that when you see brain lesions, it's associated with adverse outcome. More than 50% of the cases that had brain lesions, the outcome was poor with neurological morbidity or resulting in death. And this number comes from a meta-analysis. It included 8 studies. Most of them did not use fetal MRI, and they found brain lesions in 2% of fetuses, similar to what the French group found. And this MRI study, coming from the group in Leuven, they did an MRI on a cohort of 125 fetuses and found brain lesions in 5% of cases. Importantly, in 2/3 of these cases, the lesions were found only by MRI. So this just stressed the importance of using MRI in order to detect brain lesions in following treatment for TTTS. So the next question that we ask is how early can we detect the brain injury after laser treatment, and whether there is cerebral damage maybe before the laser ablation. So regarding the first question, one tool that we can use to detect damage quite early after treatment is to use the diffusion weight imaging, DWI. This technique, we measure the Brownline movement of particle in a tissue. We know that this movement is reduced in tissues with rich cellularity, like we see in edema that is associated with acute ischemia. So the DWIs allow detection of the acute ischemic injuries before the volume loss become evident. So we took on a study including 30 pregnancies that underwent laser ablation, and all these patients underwent diffuse weight imaging 24 to 96 hours after the procedure, and then a follow-up MRI at 30 to 32 weeks. And we found a few cases, like 6 cases that had minor bleeding in the diffuse weight imaging, but they all had normal outcome. But there were 3 cases that had evidence of ischemia. And these 3 cases had poor outcome. 2 of them had the following MRI showing a large infarct, and one case resulted in intrauterine fetal death. So you can see here in this example, you can see the hyperintense signal on both hemispheres. So this indicates ischemia. And eventually on the follow-up MRI, you can see the brain atrophy and the ventriculomegaly. So what we showed that the DWI can demonstrate cerebral damage immediately after the laser ablation or within 2 to 3 days. The next question that we ask is whether brain damage can occur before the treatment. And there's only one study from the US looking with MRI and DWI on TTTS patients before laser treatment. And you can see here that in 10% of fetuses, there was abnormal findings on the DWI. Most of the findings showed diffusion restriction, so that indicates ischemia. And there were some cases showing germinal matrix hemorrhage. There was no correlation between the presence of brain findings and the staging, but it did correlate with decreased survival. So obviously, when we have brain findings, the prognosis is usually less favorable. So I will move now to talk about twin anemia polycythemia sequence. So TAPS, as we call it, can occur spontaneously in around 3 to 5% of pregnancy, or can occur after laser treatment within a few weeks. And the diagnosis is based on intertwin hemoglobin difference without the signs of polydrums that we see in TTTS. And we based our prenatal diagnosis on increased MCA in one fetus and decreased or normal MCA in the co-twin. We don't look at the absolute values of MCA, but we use the delta MCA, and we use a cutoff of more than 0.5 mole as a cutoff for detecting TAPS. And we know that the underlying cause of TAPS is again anastomosis, but it's a very tiny vascular anastomosis of 1 millimeter, causing a very slow transfusion of blood from one twin to the other. So the data on the long-term outcome after TAPS is not as elaborated as we saw in TTTS, actually quite limited data. One of the studies, again, from the very good group, the excellent group from Leiden, led by Enrique Lepriore. And this is a study on patients that had spontaneous TAPS. It included 74 children, again, without TTTS. And you can see in terms of the prenatal therapy that it was all over the place. And the reason is that I think there's still not a consensus what is the right prenatal treatment for TAPS. So you can see that some of the cases were treated by laser, 10% received transfusion, 30% had expected management, and 30% were diagnosed only after delivery. So it's still an entity that we miss quite a lot. So when we look at the long-term outcome of TAPS, I think it was quite surprising and disappointing to see that the morbidity is higher than we expected. So the rate of severe morbidity was 9%, but there was a big difference between the anemic twins and the polycythemic twins. So the anemic twins had an 18% risk of severe morbidity, and the polycythemic only 3%. This is unlike in TTTS that we said that the donors and the recipients have similar risk of neurological morbidity. About 31% had any neurodevelopmental impairment, so that includes mild and severe. But what was very surprising is that there was bilateral deafness in 15% of anemic fetuses and none in the recipient. And it was surprising because we don't find this rate of deafness in other entities of anemia like isoimmunization or parvovirus. So it's something that we really don't know how to explain. So again, following these studies, we wanted to see what is the rate of brain injury that we can detect prenatally in cases with TAPS. So we included in our study 23 women with TAPS, and we included both 13 cases of spontaneous TAPS and 10 cases of post-laser TAPS. And these pregnancies were followed again by neurosonogram every 2 weeks and fetal brain MRI at 28 to 32 weeks. And you can see here that in 15% of fetuses, and almost 26% of pregnancy, there was evidence of fetal brain injury. So we had 7 cases of evidence of fetal brain injury. Again, the lesions were either ischemic lesions or hemorrhagic lesions. It included both post-laser TAPS and spontaneous TAPS, but was a bit surprising. And in contrast to the postnatal study, most of the cases involved the polycythemic fetuses. So we had 5 polycythemic fetuses and only 2 anemic fetuses, which is in contrast to the postnatal developmental study that I just showed you. We tried to, this is one of the cases. It's a post-laser TAPS at 29 weeks. This is the anemic twin, and we can see that there was a hemorrhage in the area of the cerebellum, resulting in damage to the cerebellum. So we tried to define the risk factors for such brain lesions in pregnancy with TAPS, and we could not define or see any difference between the cases with brain lesions and the cases without brain lesions. There's a recent study on fetal brain lesions from Italy. This is an MRI study on 29 pregnancies, and you can see that they found MRI findings in 24% of fetuses. Some of these findings were mild findings, but some of the cases they found either ischemia or hemorrhage. But in their study, most of the affected fetuses were the anemic twins and not the polycythemic. So this is actually correlates better with the postnatal study. So today, this is the only data that we have on the evidence of prenatal injury in pregnancies with TAPS. I will now move forward to speak about co-twin death in monochorionic twins. So spontaneous death in monochorionic twins. This can happen sometimes in the context of some complication like TTTS, but also in uncomplicated so-called monochorionic twins. And what happens when you have a death of one twin, the surviving twin can bleed into the disease twin because of the low resistance. And as a result, you get hypotension, and as a result, you get hypoxemic brain injury. And this can occur in about 20 to 30% of the surviving twins. So again, we can try to detect brain injury quite immediately after the event by using the diffusion when imaging. It allows, as I said, identification of acute ischemic injuries before we get volume loss on one hand. On the other hand, we have to be cautious with the interpretation of this finding because sometimes the findings that we find by DWI MRI could be transient because if you get to a perfusion, the injury is very uncommon to see persistent injury. So we can use it to detect the injury quite immediately after the event of fetal death, but we always have to try to interpret the findings very cautiously. So this is one of the kind of large series of monochorionic twins with single fetal demise. So this series, the median gestational age at demise was 25 weeks. And in 26% of cases, there was evidence of cerebral injury. So that's usually the rate that we quote for brain damage in the surviving twins following death of one of the twins. This is two examples from this series. This is a case of a twin that had fetal death. One twin died at 31 weeks, and the patient was delivered at 36 weeks. And you can see this is a surviving twin with destruction of the posterior hemisphere. The case that we see on this side is a fetal death that occurred at 36 weeks, and she was delivered 2-3 days afterwards, and you can see damage to the basal ganglia and to the white matter injury. So in their series, when they try to define the risk factor for cerebral injury following single fetal death, one of the risk factors was advanced gestational age. So in patients that had fetal injury, the gestational age at fetal death was 27 compared to 23 weeks in patients without brain injury. If there was TTTS before the fetal demise, it increased the risk and lowered gestational age at birth. Another risk factor for brain injury following IUFD is elevated MCA. You can see in this series that patients, if you have elevated MCA immediately after the fetal death, the risk of brain injury is close to 50%. So almost 50% of fetuses who had elevated MCA after fetal death had eventually evidence of a fetal brain injury. And this study, which is quite a recent study on 68 pregnancies with single IUFD, in this series, only 16 cases were actually spontaneous. The other cases were following fetal therapy. So we know that after fetal therapy, the risk of brain damage is much lower. So they ended up with a cerebral damage rate of 20%. But what's nice to see about this study that they really defined very precisely the risk of neurological damage according to the gestational age at the occurrence of IUFD. So you can see that if the IUFD occurred before 17 weeks, there are no cases of brain injury. But if it occurred above 24 weeks, the risk approached 40%. So it's quite clear that the gestational age is a risk factor for brain injury in the surviving twin. So what is the management following single fetal death in monochorionic twins in our department? So we, first of all, measure the MCA immediately when we make the diagnosis. If the MCA indicates anemia, we can consider doing intrauterine transfusion if the patient wants to do everything for the baby. So obviously, the intrauterine transfusion can save the baby, but it will not prevent the brain damage. Then we do a diffuse brain imaging MRI within 24 to 72 hours after the diagnosis, and then we do ultrasound follow-up. If the diffusion weight imaging is abnormal, then we repeat the brain MRI in 3 weeks. If the diffuse brain imaging is normal, we will do an MRI at 30 to 32 weeks. This is just a nice series of 7 cases of fetuses following single IUD that had severe anemia and they underwent IUD, intrauterine transfusion. And you can see that out of these 7 fetuses, only 2 fetuses had normal outcome. So just stress the message that transfusion can save the fetuses, but it not prevent the brain injury. It's something that is also important to tell the patients as well. So one of I think the major question in terms of single fetal death is, let's say you have single fetal death and you do ultrasound follow-up and MRI follow-up and everything goes completely normal. Does it rule out any neurological impairment? Does it guarantee normal neurological outcome? So this question, I think, is still unanswered. We still need more data to answer this question, which is I think it's a key question. And the second issue is what happens if you have a fetal demise late at gestation at 32, 34, 35 weeks, because we don't have enough time to follow the brain of the surviving twin. We definitely don't need to deliver to deliver the patient immediately, because it will not prevent the brain damage. So we need some time to evaluate the brain. We can use the diffuse brain imaging and then get as much data as we can on the brain of the surviving twin. So I would like to conclude with the take-home message of this talk. So first, we saw that survivors of laser ablation for TTTS and twins complicated by TAPS are at risk for brain injury. And this brain injury can be detected prenatally by ultrasound and MRI, and it's important to use the MRI. So it's important to incorporate both neurosonogram and fetal brain MRI into the routine surveillance of such pregnancy. The major risk factor for such brain injury in following laser ablation is incomplete surgery resulting in TAPS and recurrence, and later gestational age at laser ablation. And the major question that I will leave it as a question because I don't have an answer for it is, do normal neurosonogram and normal MRI after laser treatment guarantee normal neurodevelopmental outcome? This is still a question that we need to answer, and we have to gather more data. So I will finish my talk with this open question, and I'm happy to take questions from the audience. So thank you very much.
Thank you so much, Yoav. If you can maybe just clear your slides so we can have everybody together, and then have people ask questions. This is obviously very humbling data for anybody who's involved in the management of monochorionic twins, whether TTTS or fetal growth restriction or anything else. If you can just stop sharing. Thanks. I'll let others ask questions first.
Hi, thanks for a great talk. I don't know whether you mentioned this or not, but are there robust enough studies of pre and post MRI laser, before the laser, and MRI done on the twins, and then after the laser, to really know whether this brain injury preceded the laser or followed it? So
actually, there was only one study doing MRI before the laser, and this study showed that 10% of them had either ischemia or hemorrhagic infarction. So there's no study that really followed them before laser and after laser. Okay. It's difficult to run such a study. First, usually when we get, as you know, when we get a patient for TTTS, we don't have enough time to organize a laser MRI before the treatment, because usually we do the treatment within a day or two. But this is something that needs to be done. So to try to do a follow-up MRI before laser and then maybe 3 weeks after laser, and another one at 32 weeks, and see when we get this brain injury.
Thank you.
Anybody else? What's the effect of fetal growth restriction as a confounder in some of these cases, meaning TTTS with FGR or TAPS with FGR or demise with FGR? Like, how much does that play a role in the injury? And just anecdotally, I would say that in our TAPS, I don't know about neurological injury, but we've definitely seen, if I had to guess, worse outcomes in the polycythemic and not in the anemic. So I think it's more with what you're seeing in your center than what's been reported.
Yeah. So in terms of IUGR, we didn't find it as a significant factor in our cohort for brain injury, although we know that IUGR by itself is a risk factor, especially if you have abnormal Doppler for brain injury. We did find it in another series as a risk factor for survival. So we know that when we have TTTS and IUGR combined, then the chances of survival following laser is decreased. In terms of polycythemia, I mean, we also saw a lot of, we do see a lot of we saw in our cohort more brain injury in the polycythemic twins, but in the postnatal study by the group in Leiden, it was quite clear that the anemics are at much higher risk. And it's actually important because we had a few patients with TAPS lately that actually they wanted to have selective termination. And because of this, especially because of these numbers of severe morbidity. So when we have to choose who to reduce, based on the data from Leiden, we chose to reduce the anemic twins and not the polycythemic. And obviously, we do before the reduction, we did MRI to see that the brain looks okay. So if we have to choose if we're thinking about reduction, assuming that the brain imaging is normal, I would go for the anemic twins based on this study.
And what do you quote neurological injury in survivors after RFA? I know you didn't talk about it, radio frequency ablation.
Actually, very low, like a few percentage. So after selective termination, both RFA and bipolar, in our series, we have a very low rate of neurological morbidity and also brain finding. We do, on all the RFA that we do MRI at 32 weeks. And it's quite rare to see any brain findings in this population.
I have just a couple other questions. You had mentioned TAPS and selective reduction. What procedure do you use for that?
So it depends. It depends also, like if there's the oligohydramnios in on the fetus that we reduce, we'll probably use the RFA. The last that we did, it was at 29 weeks, so quite advanced gestation. So we either use RFA or bipolar.
Bipolar. Great. And then you had mentioned brain damage globally after single fetal death. Do you have numbers for the percent of brain damage after a single fetal death after a laser that occurred after laser treatment? What is that number?
So I don't have that. The numbers are supposed to be much less. I mean, if the ablation is done in a proper way and we don't have any anastomosis left, then it shouldn't influence the other twin. So the numbers are significantly less. Like I assume I would guess that it's around less than 5%. I mean, if the ablation is done in a proper way.
Thank you.
I had just a general question. Thank you, Dr. Yinon. But I was curious, I know our center is part of the NAFNet TTTS registry, and it sounds like your institution is doing more of a single institution data collection and registry of your own, and then you were referring to another center in Leuven, if I recall correctly. But is there any existing collaborations across these centers or any opportunities for, let's say, meta-analysis for pulling data, or are they really working in silos?
Actually, there are collaboration. For example, now there's a study called the Citrus study that is also run by the Leiden group. So they're gathering all the data on single fetal deaths in monochorionic twins and brain injury. So we're also taking part in this study. There was one meta-analysis that they showed on brain injury TTTS. I think it was authored by Asma Khalil from London. So there are collaboration on this topic of brain injury, whether in TTTS or following fetal death. So I think that Citrus study from Leiden will be like a very important study because they're going to look first on the risk and risk factor for brain damage, and also on this question that I just raised: if you have normal imaging after single fetal death, what is the neurological outcome? Is it completely normal, or what is the residual risk? So I think there's good collaboration on this.
Great. Well, thanks everyone, and thank you so much, Yoav, for joining us. And I would say staying late, but I don't normally stay even later than this, so I won't excuse you from that. I won't excuse you from that. And we hope to see you soon. Come visit us.
Welcome.
Bye-bye. Thank you.
Thank you.